being a neglected burden, this goes without saying. It needs more attention now to my study. Under this title, our perspective is the controlled clinical trials for novel antibiotics and antifungals are needed for the management of Mycetoma patients. The pharmaceutical market is actually very rich in potent antifungal agents targeting ergosterol biosynthesis, targeting the DNA, and extra. But on the but these agents fail to help Mycetoma patients. The endogenous ability of the fungus to synthesize the DHA melanin, dihydronaphthalene melanin, is proven to be the main reason behind the Mycetoma antifungal resistance. Our objective is how to overcome this DHA melanin as a new additional strategy for targeting fungal pathogenicity and virulence. You attack the virulence directly. Attacking of the virulence. You see, the idea behind having such a local solution. I will show you the system by which or the system we followed for the development of herbal medicine against Mycetoma. You see, the tyrosine is the major precursor for the synthesis of, or for the biosynthesis of DHA melanin. You see, the first enzyme will on the pathway is the tyrosinase. Tyrosinase actually is a copper-containing enzyme, which can be chelated by many medicinal plants. These medicinal plants are available here in our country, and it was being the basis of you can block the tyrosinase enzyme by chelation. The same as that happens for the tetracyclines, with calcium products and aluminum products and so forth. You see here the tyrosine goes by the tyrosinase enzyme, which can be blocked by many of the flavonoids, the diphenols, as we will see a little later. The merits for plant-based pharmacotherapy, the possible use of natural products in different pharmaceutical formulations simultaneously where appropriate, as being systemic for topical application and microfiltration technique. For the medicinal plants, as far as the toxicity is studied, you can use multiple routes for drug administration, more than one for the same natural available product, or combination of more than one. You can use the systemic, at the same time you can use the topical application as we saw by the natives, and the microfiltration technique, which works in localized infections like the Mycetoma. The Mycetoma is a localized infections, and it remains for a very long time localized. You can do the infiltration. The microfiltration technique is now used in the United States in the management of malignancies. You will have the minimum side effects because of having localized activity and so forth. For the basis for plant selection was being as follows. The first one was the suspected anti-Mycetoma activity of natural origin due to the presence of reported data of antifungal activity. This was being number one. B, the suspected anti-Mycetoma activity is anti-tyrosinase effect of many natural agents, including the phthalates. The phthalates, by the way, was being established in the melanin biosynthesis pathway as being melanin inhibitor, DHA melanin inhibitor, the phthalates, and we have a lot of plants, medicinal plants, available here in Sudan, uselessly available on the streets and everywhere, containing the phthalates. For example, the Acacia nubica, al-laut. العود containing a lot of phthalates, and the bioamines and amino acids, the quinones is available in the Nigella sativa, the cymoquinone and the other quinones. The quinone is a precursor for the production of the tyrosine, and you can interfere with the melanin biosynthesis by having the quinones are available, and the plant that which is very rich and very famous in the quinones is Nigella sativa. You know the Nigella sativa, and now used as in the management of in the management of schistosomiasis. The Nigella sativa is what is called yes, okay. The synergistic activity exerted by this, the native reports, there is no medical use and locally available and accessible species. To my research, this was being the plan for the methodology we followed. Getting from the active part, the active isolate, up to the marketing and the possible synthesis of pharmaceutical processing, pharmaceutical formulation, production, and marketing. The current results, 1 to 7 plant species, from 1 to 7 have been selected for their anti-mycetoma activity according to the above mentioned criteria. The methanol extracts of these plant parts obtained by maceration, 72 hours were used. You see the plant extracts under investigation were used for the crude methanol extract, the hexane fraction, and the methanol fraction. The methanol fraction of this compound was actually derived from the Bacillia babyrifera. It will be given a name. Hopefully, it will be given a name from the Bacillia. It is the most active extract among those tested. Has been subjected to further phytochemical investigation using column chromatography, TLC, preparative TLC, and to obtain 4 fractions. For fraction 1 was the degraded product at the base. Fraction 2, the pure single isolate of melting point 130 to 135. This was being the active part against melanin. Okay. The methanol fraction of plant X, material fractions or isolates obtained from the methanol extract of plant X will be further subjected to chemical analysis for characterization, possible synthesis, biological and clinical testing towards pharmaceutical finished products thereafter. This is the plant extract. This is MICs. As you see, it is when we start, it was being about these figures as compared with the azole group, getting very fast. The plant extract number F2, this is the pure isolate, okay. These are some of the pictures we got from the Erasmus.
You have 2 minutes to conclude your presentation.
Okay. As you see here, this is the lower line. This is for the control. You see, the first one for the plant extract number 1. The second for 2, 3. These are all of the same origin. This is Bacillia, and the number 4 and 5. This is for Acacia nubica. Some number 6 and 7 for the Nigella sativa. They all showed activity. This was being made with Dr. Windy at Erasmus. You see. Okay. To sum up, there is a chance for inhibition of the DHM melanin using these polyphenols, particularly in some of these plants are having containing the quinones, which precursor for the tyrosine, and at the same time they contain the flavonoids which can chelate the cover of the tyrosine and block the tyrosine from doing its function, as well as the activity on the DNA being an immunomodulator, and this is okay. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Now we move to the other side, which we think is very important, the immunological side of protection or effective management of mycetoma patients. So I'll introduce Dr. Muhammad Ali. Is he here? Fatma. Okay. Fatma Muhammad Ali, she will talk about immunomodulation properties of Prosopaginosis extracts in correlation to their antifungal activity. Fatma from University of Juba. Yes. You got 15 minutes.
Okay. Assalamu alaikum. Assalamu alaikum. Welcome to our guest. We hope to spend a good and a nice days in Sudan. Audience, assalamu alaikum wa rahmatullah. My talk is about immunomodulation properties of Prosopis chilensis plant extracts in correlation to their antifungal activity against Madurella mycetomitis. This work some of this work is done in Sudan, the other is done in Pakistan, Panjwani Center for Molecular Drug Research, Karachi University, Pakistan. This with Professor Mycetoma Muhammad Ahmed. Immunomodulation properties is referred to the change in the immune response involving induction, expression, amplification, and inhibition of any part or phase in the immune response. The reactive oxygen species will be either suppressed or stimulated. Stimulated compounds could have opportunity to being immunomodulate or enhance innate immune response. On the other hand, suppressing compounds can be used either anti-inflammatory or immunosuppressive. Many therapeutic effects of plant extract are merely due to their influence in immune system of human body. Phagocytics is a process which separated into several major stages. Chemotaxis is a migration of phagocytes to the inflammatory site, attachment of the particle to the cell surface of phagocytes, ingestion or phagocytosis, and intracellular killing by oxygen-dependent in the oxidative process activity or oxygen-independent mechanism. We use for the oxidative pairs activity, we found different disorders, various disorders related to innate immune response and to evaluate the effect of drugs. We have NADPH oxidase is the enzyme responsible for the production of superoxide ion, which is quickly converted into hydrogen peroxide and hydroxyl radicals, which are the oxygen reactive species. This mainly being in the immune system, which compose of the monocytes, neutrophil, mast cells, and all phagocyte cells. We have the cascade of the reactive oxygen species production in the oxidative base. Upon stimulation, granulocyte and monocyte produce reactive oxygen metabolites in a cascade of events, as we see in this cascade. The events start with the production of superoxides, اللي هو superoxide ions like hydrogen peroxide, hypochlorous acid, which destroys the pathogen inside the phagosome. The formation of the reactive oxidant during the oxidative burst can be monitored by the addition of luminol or leucine. Also, we have immunomodulation for the lymphocyte cells. We use lymphocyte proliferation based on their ability to interact with the cell of both innate and additive adaptive immune response. The T cells proliferation is served as T cell depletion induced by ionizing or radioactive chemotherapy or pathogen infection, or may be due to the expansion of the T cells population by cell division followed T cell activation. Cytotoxins are produced by many cell types in response to infection and act on the bone marrow stem cells, which stimulate proliferation and maturation of immune response cells. Cell proliferation, in particular T cells, measures the number of the cells generated and survive in the culture following the action of stimulus. Here we have the procedure for collection of the blood sample from a volunteer. We have 10 to 20 ml blood samples can be treated by hypotonic solution so as to suspend granulocytes and lymphocyte cells, as we see in step A and B, C, and D. As the last, we have a suspension of hypotonic solution containing the cells which is used in the immunomodulation test, as we see in our work. For the plant, this is the Prosopis chilensis plant. This is a plant introduced from Chile to Sudan to combat desertification, and the trees grow well and in breeding condition and considered as useful plant. People in the south use this plant, use the macerated leaves for malaria as anti-malaria drugs. Some people use it for antimicrobial activity. Type methodology, we use luminol enhanced chemiluminescence assay will be performed by following procedure described by Helfand and Halkar. Luminometer results were monitored as chemiluminescence relative light units with peak and total integral value set with repeated scan at 30 second interval and 1 second point measure time. T cells were proliferated following the method reported by Nelson et al. 1998. The level of proliferation response count per minute, CPM. Cereal concentration from the Prosopis chilensis leaves and bark and the root. I use different types of parts, the leaf and the root and the bark. I choose different concentration, 200 to 150, 25, 12.5, 6.25 microgram per mil. This is for my extraction results. Normally, neutrophils eliminate the pathogen at the site of infection through phagocytosis. To ingest pathogens, neutrophils recognize either a molecule on the surface of invade microbes or their opsonization with serum host proteins, including complement factors, mannose binding lectin, or antibodies. Oxygen reactive species like hydrogen peroxide, superoxide, and nitrous oxide are formed which effectively kill ingested microorganisms. As we see in my results here, I use different extraction from the leaf methanol extract and modulated with the whole blood cells containing monocytes, macrophage, and neutrophil. We have the inhibition percentage for the leaf. For the concentration 200 to 100, we have above 100% inhibition. This means that the leaf is very active as immune modulation for the whole blood cells. Second, the bark from this plant, the highest concentration is 200 micrograms, also cause inhibition of 80%. And the least one is the root, which show less than 70%. The highest, the leaf extract show dose-dependent effect with more than 90% inhibition at highest concentration. 200 microgram and 100 microgram. These have effect on the cell response, as we see in the histogram. For the neutrophil, I separated the neutrophil for oxidative burst activity. For the 3 extract from the leaf and the bark, we see the inhibitory properties, inhibition percentage for the methanolic root extract for the bark and the leaf, and from the root on Prosopis silensis on the neutrophil. We use the luminol base for this activity. The leaf extract is with the highest inhibition percentage for yes. This means the leaf have a good inhibition activity. Second, the bark. So we go to the T cell proliferation. Also, we see the leaf has a good activity. For the antifungal activity, we use the same extract for Prosopis silensis, the leaf and the bark and the root. We use the method of National Committee for Clinical Laboratory Standards. This method established by Wendy and her colleagues in 2007. I use controls for my work is ketoconazole 1 milligram. Also, the leaf and the bark exhibit a good activity. And the MIC for range from 1 to 0.05 milligram per 2 mil. Yes, this is susceptibility for the leaf and the bark, different concentration. And also I use different fraction from the leaf. I use the methanol, the aqueous, and ethyl acetate, and 2 fractions from the petroleum ether extract. And this is show also the leaf, the most active fraction against Madurella mycetomyces as antifungal. For our conclusion, naturally occurring metabolites are used therapeutically to be effective or killing or inhibit the growth of microorganisms without harming or being toxic to the host cells. Crude methanoic extract for the leaf of Prosopis silensis, so the most potent active species. The activity of this extract is attributed to the synergetic effects, so that immunosuppressive activity is a strong support. The common is botanical use for this plant as anti-inflammatory and antimicrobial action. There is a correlation between the susceptibility of Madurella mycetomyces and immunomodulation from these extracts. Large number of neutrophils are present. For the mycetoma, we see the large number of neutrophils are present as a site of inflammation, so that we can use this method or this protocol for the treatment. The production of superoxide can destroy the microorganisms inside the phagocytes. The formation of reactive oxygen species during the oxidative burst indicates the high inhibition percent as an antifungal agent. Extract from the leaf and the bark of this plant species contain a high content of oxidative burst in the phagosome, indicated by the high inhibition percent, can use as antifungal agent. Conclusion: plants may play a high significant role in drug discovery and development process. This was particularly evident in the area of infectious disease. Prosopis silensis leaf extract has a promising antifungal agent. Prosopis silensis is a rich source of antimicrobial and immunomodulation substance. Majority of isolate of compounds from this plant possess a good or significant antifungal activity. These compounds may be considered as candidate for developing immunosuppressive or antimicrobial agents. This is the reference for, and thank you very much.
The next speaker, somebody who is well known to all of you, Professor Ahmed Hassan Fahal. Professor Ahmed is a classmate. We had been through the difficult and easy time together. And all I can say, he's a talented surgeon, he's a medical educator, and he's a scientist. Although I know that the character of being a surgeon sometimes predominates even in his discussions. Professor Ahmed, we are looking forward to listen to the verdict in the management of mycetoma. And being a surgeon, I may say that it is surgery, and we know how it helps. Professor Ahmed, we are all waiting for you. Thank you.
Okay, Okay, thank you very much, Mr. Chairman, for this nice and kind introduction. And yes, surgeries had a lot of influence, but not so bad, as somebody may thought about it. Okay, in the coming few minutes, I'm going to discuss the surgery of mycetoma. The objective of this presentation, it is to give some ideas, share experience, and some conclusions on the surgery of mycetoma. And the content will be how to prepare the patient to surgery until he come back out of the theater. The indication for surgery in mycetoma patients can be either for diagnostic purposes or for therapeutic purposes. For the diagnostic purposes, you have a wide local excision, or you can have a simple biopsy. A biopsy should not be done under local anesthesia. Should be done under general anesthesia, or should be under spinal or block anesthesia. And it should always be as deep as possible to include grains in the specimen. A biopsy done under local anesthesia, it is absolutely not useful in many cases, because in many cases you don't have an enough amount of grains which can be used for the culture or for histology, and nowadays for the PCR identification of these cases. In many centers, it is done at the level of the PCR identification, as mentioned kindly by Dr. Hild just a few minutes ago, because you would like to know what grain, what strain is there, and what's the treatment for them. For the for the surgical treatment, we usually will start with a proper medical treatment first. And this is a slide of a patient underwent surgery, and before that he had a 6-month treatment with ketoconazole. The treatment with medical treatment is important to localize the infection, to develop a well-developed capsule around the needle so as that can be removed. I know with a small lesion seen by many surgeons, you don't need to do this, but it should always be done. Medical treatment prior to surgery, you would like eventually to have a capsule like this, because the recurrence is 100% with no proper surgical and medical treatment for these patients. Unless very small, localized, can be well excised, and still you don't know, this patient may develop recurrence. We saw patients 20 years after the primary surgery, and they came with recurrence. And that is why yesterday I emphasized the fact that it has a malignant behavior, mycetoma. We saw a lot of patients coming with transplant, with immunodeficiency, and they have recurrence after 18 years from the first surgery done for them. This is the capsule seen under the microscope. You can see how thick the fibrous tissue in this patient. This is a capsule in a patient with a brain mycetoma. You can see how thick the capsule of the lesion. This is Mr. Arbab. He's performing this surgery. And again, this patient had an adequate course of ketoconazole prior to surgery. And the aim of medical treatment is to form a thick capsule like this so that the surgeon can be able to deal with the lesion after that. We have to prepare this patient properly for surgery. We cannot go for a brain surgery with a mycetoma patient like this without having a proper MRI in such patient. I mentioned this morning MRI is important, not in all cases, in a patient like this. You have a decision for doing an amputation in a patient, and without an MRI like this, you cannot go in a brain of a patient like this trying to remove it without a proper investigation to reach a diagnosis. These are the patients we are dealing with, not the small lesions which can be done anywhere. But always in the center you have a problem like this, a patient coming with a huge massive lesion like this, And here we have to plan our treatment for this. Shall we go for a wide local excision? Shall we go for a multiple sessions of excision, and that is the bulking surgery? Or shall we go for straight away for an amputation? And then you have to consider the reconstruction of the site of the surgery at that site. Sometimes you see a patient coming with surgery with a lesion like this, and there is a thorn in the lesion. Once you find this, we will be very happy to have identified the thorn, and you have to do a lot of investigation for this thorn because the pathogenesis of the problem is still unknown for us. We usually take this thorn for culture and for histology, and nowadays are looking for PCR identification what's happening in this zone, because if we can know what is happening there, we can have a better understanding for the pathogenesis of the disease. Local excision. This is a patient came with a mycetoma. The plan was to do an amputation somewhere, in another hospital. This is the excision, and then you can see how massive the grain studied in the lesion. You can see here the grain, it is almost plastered with the tissues, and you have to do some manipulation to remove these grains. And now you can have the cavity in the bone, you can see it properly here, and that has to be excised properly. A cavity starts to be getting bigger in size, and now even you can see through. This is the type of the patient they need an MRI. They need an ultrasound. They need a proper preoperative management of this patient. And then you can see still the lesion going on. Still there's a bone cavities here. And this is at the end of the surgery. You have the washing with the normal saline and iodine. Still washing here. Then we remove the tourniquet, and you can see how massive the bleeding is. And I'm glad to say this is the dressing. We usually will keep the dressing for 2 hours, and then we release the dressing to avoid having ischemia of the affected part. This is a bone. You can see the bone cavity with a lot of grains inside. These are the grains, scooping them from the lesion. And this is the patient just few weeks after that. And even such patient may develop recurrence after such a surgery at this site. Compare the preoperative and the postoperative pictures of this patient. Another patient, you can see how massive the facial infiltration of the grains. The tissues are brown in color from the pigment produced by the organism. Trying to remove them, we are removing the dead tissues, the affected tissues, the fibrous tissues. Even you can see through. This at the end of the surgery, after washing the area with a normal saline, you can see most of the tissues now they look healthy, but you cannot be certain what is happening in the tissues there. Hyphae is still around, small grains is still around. So this is why medical treatment should be combined by preoperative and post-operative course at this patient. A cavity at this side. This is a patient 3 weeks after the surgery, and he is waiting for a skin graft to be applied in this patient. The other modality, this is another patient. Again, this patient had a course of itraconazole for 6 months. The plan was to amputate this patient. A young lady, she was 19 years old, she coming from a Jazeera area with multiple problems. You can see the grains here. She had a surgery, wide local excision, and this is her post-operative photo at this side. This lady, she was followed for 18 months, and she developed massive recurrence, and she ended in amputation after all these surgical techniques. So still we are having a problem. It is not a simple problem known by the patient, by the nurse, by this and this and this, and you don't need to have a proper diagnosis for it. This is a lady came with a small lesion in the shin of the leg at this side. Bad dressing, secondary bacterial infection is common in this patient, and you can see how big the cavity in the bone in this patient. Exploration will show how big the cavity. And what I would like to emphasize here, the external appearance of the lesion, it is always deceiving, and it is always trying to avoid local anesthesia for exploring such patients. This is the same patient, and then you have the cavity, and after we finish, we wash and we wash and we wash again with iodine, trying to eliminate the load of the fungi or the hyphae in the area at that site. Even so, the patient may develop. This is a young patient, Muhammad. He is still in the ward with us. He is here at Soba for the last 2 years. Inpatient. He was referred from other hospital. They don't know what to do with him. When he came, his blood hemoglobin was 5 grams. His serum albumin was 1. He was very infected, in a very bad shape, malnutrition. This is the close view of the lesion. So what the plan? The plan was to do a debulking surgery. We started in one side of the gluteal. He had a mycetoma of the gluteal region, inguinal canal, upper part of the thigh, scrotal, and the root of the penis. We did a colostomy in this patient to reduce the load of the infection in the area from the fecal soiling. He had a catheter because he was unable to move around. He is still with his colostomy. This is the other side here. He had a massive excision, just leaving an area around the anal canal to avoid the fibrosis in the area. And this is 1 year after treatment. And this is his picture this morning. And he is still in the ward. This is the type of patient they need a proper diagnosis of the underlying organism. This is not a simple Madrella mycetomatous. Probably it is another strain. All this time he was on ketoconazole treatment, and you can see still there is no very much improvement, although he had about 30 debridement under general anesthesia or spinal anesthesia. This is the type of the patient we need to know what is happening at the level of the strain and the species. Reconstruction is important. Amputation, again, still we need some amputation to be done for this patient. If they can come late with a massive extraction, with secondary bacterial infection, and with a problem like this. Amputation uses social, medical, financial problems. She is very happy about the amputation because she got rid of the secondary bacterial infection and other problems. The important thing, again, this patient, they need a prosthesis if they have amputation on the limb at this site, and this is not available in all centers. What type of surgery? What type of anesthesia? Sorry. We have different types of anesthesia. Usually we don't do local anesthesia this is a patient with a single sinus in the lateral, in this side of the malleolus. On exploration, you can see how massive the lesion is. Very big, two cavities, full of grains, and a lot of tissues around were affected. The intubation in some patients will be difficult like this. And this lady had a massive mycetoma of the head and neck. It was difficult to anesthetize her. She had a locked jaw. This is the maximum she can open her mouth. She was eating only fluid. And this is the type of the patient they need special care. You have to do a nasal anesthesia in this patient. And then this is the patient under anesthesia. A tourniquet should be applied in this patient unless in areas where no tourniquet can be applied at head and neck at this site. And the time of the tourniquet should be calculated and measured properly, otherwise the patient is going to ischemia. This is a well-placed tourniquet. You can see how the tissues very much identified, the muscle bundles and other structures are very clear. Sometimes you do a positioning a patient like this. So surgery of mycetoma is not a simple cut and throw the lesion like this. Complications again are variable and various. Disability and deformities. This is a deformity at this site. You can have a tourniquet problems, and that will lead to nerve palsy, especially in the upper limb. So you have to calculate the time and the amount of the pressure, ischemia following surgery. A patient should always be aware that he may lose his toe, his finger with the procedure, because we may injure the blood supply at the surgical technique. Ischemia is a big problem. Ischemia, this again, wrapping the wound very tight, you will end in ischemia of the skin like this. That is why you have to release the dressing 2 hours after the surgery. Otherwise, you'll have ischemia of the skin, which is common. Post-operative hyper or hypopigmentation. Dressing should be properly done. We have various types of solution, normal saline, iodine. All this has been used and they proved to be the same. This is the post-operative healing process. Secondary bacterial infection in the wound, waiting for the dressing and waiting for the skin grafts. Skin cover should always be as soon as possible, as quick as possible. The cause of the recurrence are multivarious. It may be the experience of the surgeon, it may be the surgery itself, but always remember that you will find something missing like this. You almost leave behind the grains like this, and the grains may be the cause of the recurrence like this. It may be far away from the surgical area. It may be as far as this. Inadequate surgery will end in a problem like this. This is an amputation with a recurrence in the stomach because the plan for the treatment was inadequate before surgery, and that is the cause of the recurrence. Inadequate surgery will end in a problem like this. This is a patient had inadequate surgery. She had a bone affection. You can have cavities at this side. And this sort of patient, they need an ultrasound to see what is happening in this system. Right. Miserable recurrence in the stomach, abdominal wall with bladder. Recurrence on top of a skin graft. And again, adequate treatment should continue post-operative with medical treatment for these patients. Drug compliance is a big problem. This is the patient with a massive head and neck mycetoma. She had a very excellent. This is at one stage. She had a surgery. She did not take her drugs, and she came back with this recurrence. And then we persist. We did another excision, and she was waiting for a skin graft, and she refused. and she ended with a reasonable scar at this site. So the problem is it is the adequate pre-operative, post-operative medical care with the treatment, surgical treatment. This is the lady, few weeks after the surgical excision, and now she is on medical treatment. That was she was last time was seen in 2005, and we could not trace her follow-up recently. This I mentioned yesterday. This is a patient with acute appendicitis. He developed wound infection. He started to have grains coming from the surgical wound, and everybody was very much concerned. Probably he had the infection of mycetoma in the theater. Lucky enough, we were not blamed for that because he had a mycetoma in the back. He had a facial spread, and that was confirmed by MRI and the ultrasound examination. Cosmetic is a big problem in this patient. Still with her big wound, not healing. She is having henna and she is trying to socialize at this patient. And again, you have to remember this patient has a lot of social obligations in the planning of surgery and these other things. In conclusion, I would like to say that still we are far away from adequate treatment for mycetoma patients. This is when she is having her PhD. How many years? It was a few years ago. And we're still working with her for the adequate treatment for mycetoma patients. She is signing the wall. This is a very common habit in the Erasmus Medical Center there. After having a PhD, they sign their name in the wall with other graduates. Thank you very much for your kind attention.
Thank you very much, Ahmed, to conclude and give us some time to have a few questions. You remember? Do you remember the speakers? Dr. Hail, I was surprised that you took off ketoconazole from the list of drugs to be used against medullary mycetomatous. You didn't even put the price when you put the prices of others. And Al-Fadil magnified the side effects of the ketoconazole. I don't agree with this. We have been working with it since 1980. We have many patients with it now in the center. Okay, you get some side effects with the high doses, but we still, Ahmed was giving it to develop his capsule, and I have used it with some people who actually got cured. So I don't think, now we are doing some in vitro sensitivities, we find it quite superior to itraconazole, fluconazole, and so on. It's only match, or even voriconazole might be even much more. So may I have your comments on Wendy's as well, because now is the drug we use regularly here for our mycetoma patient. Thank you.
Thank you, Professor Mahjoub. I'll tell you first a funny story about ketoconazole. Well, the other case was actually a patient that I have treated with ketoconazole and she was cured, but the bone was safe. I mean, it was not involved. I wrote ketoconazole for that patient, and then I got a call from the pharmacist. And they said, you're writing, we usually write the indication. So I wrote ketoconazole, indication, mycetoma, or fungal mycetoma. So the pharmacist called me and said, how come you're writing ketoconazole for for mycetoma? In my book, it's itraconazole is the drug. So please change it or write Form B. Form B is a non-indication for a drug for non-indication. So it's very tedious. So I spent like 10 minutes trying to explain to her, but so people are kind of away getting dissuaded from ketoconazole. No, I believe ketoconazole is a very useful drug. I took it from the coast because it's far cheaper than any of the others. Here I want to, project the ones that we are concerned about. Actually, this patient we have treated with a very high dose of ketoconazole after we have tried the voriconazole, and we failed. No, I think ketoconazole is still a very useful drug. I mean, this steroids biosynthesis issue, I haven't seen it, but maybe in high doses. I'm not taking it off the shelf, definitely, for this indication.
It's only in this respect I found great difference when using the original ketoconazole, the Nizoral, and using the ketonaz, which is new. And I think this is important. That's one thing. And again, how to give it. I find it very good when you give, instruct your patients to give it before the meals, yes, maybe with some acidic fluid, orange juice or lemon juice and so on. So it still has a place. And I don't know about the cost very well, but we have the Nizoral now for something 25 pounds and the ketonaz for 15, and I insist that you give the original.
For a week.
For a week, yes.
For a pack, yeah.
Which is not bad. It's not $130.
Yeah, we still are using the ketoconazole in the treatment of these patients, but it is a dose dependent. When you use them in the ordinary dose, 400 milligram per day, the response is not very good. And that was seen in the clinic. We increase the dose to 800 milligram per day. You have a lot of side effects. You have, thank God they don't have a liver toxicity. Sometimes they develop some enzymes disturbances. But jaundice per se is not seen in none of our patients, although we are using a lot of this drug in these patients. They develop a very interesting feature. They develop skin hyperpigmentation, they develop dryness of the mouth, dryness of the lips, and some of them will develop gynecomastia in these patients. I remember when we started giving this patient this drug, one of the patients took the prescription to the pharmacy, and then he came next day and said, the pharmacist said, don't use this drug, this patient is going to kill you. For 6 months to give this ketoconazole. So now we're writing it, we're putting it in our center prescription, we put it very clear that, so as make sure that the pharmacist will not be confused about the drug at this site level and the drug dose and this. So it is a very serious drug if you give it in a high dose. The problem is a dose dependent. If you use it in the simple dose described by Professor Sheikh some times ago, it may not be effective in many of the cases at this site.
Still you can get some good results with a medium dose. I mean, we use 200. Ahmed gave 800. This shows you how the drug is safe. So you manage your patient obviously according to his weight, to the region and so on. There are many points to be taken when you are prescribing any drug. You can't generalize for every patient. Thank you.
If I may comment, I think what we have learned from the bacterial world, probably we should try to apply it to the fungus world. We are moving towards the yeast, like Candida, because we've noticed an albicans is not exactly like the other albicans. It's not like the tropicalis. It's not. So it's like a Pseudomonas, different than Pseudomonas. Candida is different than Candida. I think Madurella is different than another Madurella, and I think that's making maybe the difference in terms of success in the same drug used for two different patients.
Concerning the ketoconazole, it is a good drug, but going through above the therapeutic dose might be having a lot of side effects. My point is that the novel drug delivery systems. We need research about the ketoconazole on this aspect. What I said about the microfiltration, I think it can be a good choice. For the amphotericin B, now people are using the liposomal amphotericin B and they managed to quit the renal function. yeah, the nephrotoxicity you can quit from the renal by using the liposomal. Yeah, amphotericin B is a nephrotoxic drug, and the nephrotoxicity is very near to every patient. But liposomal one, you can quit from the renal function. You can the same thing for the ketoconazole, the novel drug targeting novel drug delivery systems. You attack the fungus since it is localized. The microfiltration might be helpful, but it needs some research. You can avoid the hepatotoxicity as well as the depression. By the way, is this depression assessed in your patient?
Doctor,
depression and psychosis. Okay.
Point is taken about microfiltration, and I hope we'll give it a trial. Please,
yeah, can I,
please, we have a...
Yeah, taking the discussion a bit further about ketoconazole or ITRA, whatever way you look at it, they both need prolonged treatment. 6 months, 12 months are needed to have an effect, or even more than that. Is there any reason to believe that a drug like voriconazole would be so much more effective that the treatment duration could be shorter? Or would you go for combo therapy, so combining one of those drugs with another one? Because I think trying to shorten the treatment duration would be of enormous advantage.
The problem when we're treating microbes in general, we work on the life cycle, and some of them are really slow, spore forming. They get really protected, and this is why we go for a prolonged course. Combining antifungals is now under trial for the more common fungi, like aspergillosis. A study on voriconazole and anidulafungin for aspergillosis has just been concluded. I hope it will be presented in the next ACAC meeting. A few retrospective data suggest that an echinocandin and an azole may be good for aspergillosis. But it seems to be maybe an echinocandin and a voriconazole would not be good for Medulla. We've tried it in our patient, didn't work. And very expensive. I mean, Ambisone, for example, is about $400 a day. So it's formidable.
I'm sorry, can we just bring this session to an end? Any question, just to be fair on the other side, any question from the other room?